first component is history of present illness, HPI. This is the main part of the history. This is the place where we get detailed information about the course of the disease. So what are the things we are expected to put under history of present illness? One is elaboration of the chief complaint. So we have to characterize the chief complaint in details. We will see how we characterize each symptoms, how we characterize cough, how we characterize body swelling, how we characterize pain, how we characterize vomiting, diarrhea, and the like. So there are different patient complaints. So the first thing that we should have to do is elaboration of the chief complaint. After elaborating the chief complaint, then I will also elaborate the associated symptoms, additional symptoms. For example, if our patient has a chief complaint of shortness of breath of 3 days duration, so I will start my history of present illness by elaborating or by characterizing that shortness of breath. Then after explaining the shortness of breath, I will proceed with the associated symptoms. For example, if my patient had associated with the shortness of breath, if he had chest pain, I will explain about the chest pain in detail. I will characterize the chest pain. If he had associated vomiting, I will explain about the vomiting. If he had associated wheezing, I will explain about the wheezing. So every associated symptom should be explained, elaborated, and characterized following to elaboration of the chief complaint. Then I will proceed with inserting of associated risk factors for the differential diagnosis that I have considered. So each disease or each pathologic conditions have different risk factors. So we can get those risk factors through our experience and detailed reading. So I will explain or list out the risk factors for the differential diagnosis that I have considered. Commonly known risk factors, for example, one is assessing about smoking history. Smoking is risk factors for different pulmonary pathologies and different malignancies in our body. So I have to assess if the patient is smoking or not. If he is smoking, I have to quantify. In order to correlate the dose-response relationship, I have to quantify how much he is smoking. So at least I should ask him how many pack does he smoke or does she smoke per day. For example, if a patient smokes 1 pack of cigarette per day, and if he was smoking for the past 10 years, then I can calculate or the dose of smoking as multiplying the number of pack he smokes per day by the number of years he smoked. For example, he smoked 1 pack per day and he smoked for the past 10 years. So he smoked 1 times 10 is 10, so he smoked 10 pack year. And for example, if he smoked half pack means 10 sticks of cigarette, because 1 pack of cigarette contains 20 sticks of cigarettes. So if he smoked 10 sticks, which means half pack. Always we have to change it to pack. So it is half pack. So if he smoked half pack of cigarettes per day, and if he was smoking for the past 10 years, then I can calculate it as 5 pack year, which means half or 1/2 multiplied by 10, which is 5 pack year. So this is the way how we calculate the dose of cigarette smoking. Actually, this is important, especially in a patient with obstructive lung disease, because most of the patients with COPD or obstructive lung disease have a smoking history, and there is a dose-response relationship between smoking and COPD. That's why the reason we should calculate the dose of cigarette smoking. And in the future bedsides, we can discuss the detail of this while we have a bedside session on respiratory disease, especially under obstructive lung disease. We may have further discussion on smoking. So always we have to mention these risk factors. The other thing is commonly known risk factor is alcohol. So alcohol, actually, it is permitted. We shouldn't say to the patients that drinking is absolutely forbidden. Rather, every patient should adjust the dose of alcohol intake. It is allowed for men, about 21 units of alcohol per week is allowed for men, and 14 units of alcohol is permitted for women. Actually, there is a formula to convert units of alcohol into grams. 1 unit of alcohol contains about 20 grams of alcohol. So from this we can understand that men are allowed to take about 2-3 bottles per day if it is beer, and women are permitted to have at least 1 or 2 bottles of beer per day. And there are also different calculation systems for different alcohols, because the concentration of alcohol varies across different alcoholic beverages. If the patient is taking alcohol above these limits, then we have to assess as a risk factor. Another important thing that we should assess under history of present illness is the presence of any allergy, the presence of if the patient is taking any medication. Don't forget to ask this question, because medication by themselves can be the cause of that symptom. And the other thing is, after diagnosis, we may prescribe different types of drugs, and those drugs may have different interaction with the drugs that the patient is taking. Especially patients with chronic illness like the patient, hypertensive, patient with underlying cardiac problems, renal problems, and the like, they may take different drugs. So we have to consider those drugs by prescribing the new one. They may have different interaction on their absorption, on their bioavailability, on their activation, on their excretion, and the like. So we need to know if there is any medication that the patient was taking, even including the OTC medications and also the prescribed medications. So this is among the major things that we should have to include under the history of present illness. And if you talk this much about the pointers that we should include under history of present illness, the last thing is identifying pertinent positive symptoms and pertinent negative symptoms. This might be a little bit confusing for a new medical students. However, once you adapt to it, it's easy. The concept is easy. Pertinent positive and pertinent negative. After assessing these things on our HPI, finally, we will write our history as otherwise he has no history of this, he has no this, he has no cough, he has no vomiting, he has no diarrhea, he has no loss of consciousness, he has no abnormal movement, and the like. So we ask these things because they are pertinent negative. So what are pertinent positive and what are pertinent negative? Let me give you a simple example. For example, a patient, a non-asthmatic patient, come to our hospital and his chief complaint is exacerbation of shortness of breath of 3-hour duration. So after elaborating his shortness of breath in detail, we will ask him for any associated symptoms, like does he have any cough? So that is, if he say yes, that is pertinent positive. If he say no, it is pertinent negative. The patient says no, but the information is very pertinent, very relevant in order to reach to our diagnosis. I will ask him if he has any palpitation or if he has any PND or orthopnea. So I ask this question because the pain present with shortness of breath, of course it might be asthma, it can also be heart failure. So I should ask him the symptom of heart failure. And he said, no, I have no pain, I have no palpitation, I have no orthopnea and the like. So I will understand that during the likelihood of the cause of that shortness of breath is heart failure. So this is what we call it pertinent negative. So the information that we are going to ask are each and every information are pertinent. what makes them positive and negative is the presence of that symptoms in the patient. Whether the patient experiences that symptoms or not is the major factor that makes it pertinent positive and pertinent negative. I hope you understand what pertinent positive and negative means. And so we have finally listed out our pertinent negative findings on the HPI.
Okay, let's take one sample history of present illness. As you remember from our previous presentation, our patient Mr. Muhammad, after taking the identification and mentioning his previous admission, we will mention the chief complaint, and Mr. Muhammad presented with the chief complaint of exacerbation of shortness of breath of 1 week duration. His history of present illness is presented as follows. He is a known cardiac patient for the past 2 years, taking pure medication and monthly injectable drug, presented with shortness of breath of 1 month duration, which was initially experienced when he moves out of his home, and 2 weeks later he experienced it daily, that intervene with his less ordinary activities like going to toilet. 1 week prior to his admission, he experienced a shortness of breath while he is at rest. After elaboration of the chief complaint, then we will proceed with elaboration of the associated or additional symptoms. So we will continue like this. Associated with this, he experienced shortness of breath and cough when he is on sleeping position, for which he uses 2 up to 3 pillows to relieve symptoms of the same duration. In addition to this, he experienced shortness of breath that wakes him after few hours of sleep, for which his sleeping pattern is disturbed for the same duration. He also have intermittent productive cough of 1 month duration. He has fatigability, loss of appetite, and palpitation of more than 6 months duration. So after explaining this much about associated symptoms, then we will mention about any previous admission. He is a non-cardiac patient, so we will mention about his previous admission like this. He has been admitted to this hospital 2 years back after he presented with the same symptoms and told to have heart failure, and discharged after 4 days, being appointed for monthly follow-up, having PO medications and monthly injectable benzyl penicillin. However, he has discontinued the PO medication 6 months back. Since then, he started to experience the current symptoms. After assessing his previous admission, then we will assess if he had any associated risk factors based on the chief complaint. So we explain it like this. He also doesn't adhere to lifestyle modifications, that he consumes same food of the family prepared with no salt restriction. 4 years back, he has history of joint pain involving the wrist, elbow, ankle, and knee, changing every 2 days. Since then, he also experienced shortness of breath, abdominal swelling, fatigability, and palpitation. He also has history of recurrent sore throat during his childhood. So, after explaining these risk factors, then we will search for any pertinent positive and pertinent negative findings for our patient based on our differential diagnosis according to the patient's chief complaint, which is shortness of breath. So the history is written in the line of rheumatic heart disease, but other differential diagnosis for shortness of breath can be a possible diagnosis for Mr. Muhammad. So we need to search for those pertinent positive and pertinent negative findings. So otherwise, he has no history of chest pain, chest trauma, and radiation exposure. He has no headache, fever, profuse night sweating. He has no visual or hearing disturbance. He has no vomiting or diarrhea. He has no loss of consciousness, abnormal body movement. He has no any urinary complaints. He has no aching pain or sensory loss on his extremity. He has no heat or cold intolerance. He has no skin rash or drug allergy. He has no constipation or stool color change. He has no yellowish discoloration of the eye or the skin. He has no contact history to a TB patient. He has no any smoking or alcohol use. history. He has no personal or family history of DM, hypertension, or asthma. So these all are pertinent negative findings because these are pertinent evidences, but the patient doesn't have all these symptoms. So this helps us to rule out our differential diagnosis that we considered based on our patient's chief complaint. So this is the way how we organize the history of present illness.
So this is grossly how the HPI looks like.